RedLANO, Red Latinoamericana de Neuro-oncología.
What's always nice about presenting cases is you can pick your best cases to illustrate a particular point. So clearly these are some of the best patients they've done, but I think they're very important topics that we all need to think about and design new studies for. I'm going to go through four. We'll keep on schedule to get you to lunch. The first one is a recurrent glioblastoma who recurred during their adjuvant temozolomide. The second one is a newly diagnosed glioblastoma who was asymptomatic after a gross total resection. Another newly diagnosed glioblastoma who was unresectable. And the last one I think is the toughest. It's a recurrent glioblastoma who progressed to single agent bevacizumab. So the first one, 54-year-old woman, and these are all my patients, so if you have any questions about them, I know them very well. The woman really had no past medical history. She presented with 3 days of severe headache, then had a generalized seizure at work. An MRI showed a large left parietal lobe enhancing tumor. She underwent a partial resection. They were unable to do a gross total. The pathology was a glioblastoma. The patient was treated with standard chemoradiation therapy, but progressed during her 8th cycle of adjuvant temozolomide. Her KPS had really deteriorated. She had a lot of weakness and had many seizures per day. She ended up on 3 anti-epileptics. It was very hard to control her seizures. She required a lot of steroids. There was a lot of mass effect. She was on 24 milligrams of Decadron daily. So this is the type of patient we see all the time. How would you treat the patient? Here's her baseline MRI with the contrast on the left, the flare. She actually was treated on one of our clinical trials. We try to get about half of our patients treated on clinical trials. This was about 4 years ago. She was treated with carboplatin, irinotecan, and bevacizumab. After just 1 cycle, she had a dramatic improvement. She was tapered off her dexamethasone in just 2 weeks, so from 24 milligrams to none. She continued on the same therapy. She actually was able to tolerate it for a year. It's a pretty toxic regimen, but she did real well with it. She had a cold PET scan after a year, so we stopped her therapy. We did not continue it. She was starting to get tired. She remained on single agent bevacizumab but progressed after 19 months and again had a very rapid decline. And at her second progression, she said, "I've had enough," so she opted for hospice. So here's, you could see that dramatic improvement after just 2 cycles of chemotherapy. A marked reduction in mass effect, decrease in the flare and T2. Just a couple points. I mentioned my belief that VEGF is really the prime driver of most glioblastomas. I think it's the most important growth factor. I think the addition of chemotherapy to bevacizumab modestly improves the efficacy. I understand the increase in toxicity, but if you look at all the data, the addition of chemotherapy does improve the response rate, time to progression. So it's just one of those things you discuss with the patient about toxicity versus potential benefit. There really is no one chemotherapy or biologic agent that's clearly better than any others when you combine it with bevacizumab. We've done about 20 different studies. We've tried every combination. They all come about the same. So it really just tells you that it's inhibiting VEGF. That is the primary important thing, and that we don't know what upregulates when you inhibit VEGF. I think in the recurrent disease setting, bevacizumab improves overall survival modestly in the 3 to 6 month range, but it does offer, I think, clinically relevant palliation. You're able to get the patients off their dexamethasone and things, but it really illustrates that we're very limited in our knowledge of the science, and we need better studies, better combination agents. Okay, I'm going to switch to a second case, perhaps a little more controversial. This is an asymptomatic, fully resected glioblastoma, so newly diagnosed. Healthy 49-year-old gentleman, also presented with a seizure. He had a large right parietal mass. The pathology from the gross total resection was a newly diagnosed glioblastoma. Really had an uneventful postoperative course. We saw him a week after his gross total resection. We had our newly diagnosed clinical trial, and he did opt for that. It's always a hard discussion about the pros and cons of taking on the increased toxicity of when you use bevacizumab in the newly diagnosed setting, but he wanted to participate in the clinical trial. Here's his tumor before resection, pretty large right parietal tumor, a moderate amount of mass effect. It's a nice gross total resection, a little bit of blood in the resection cavity, a little bit of blood in the subdural space, but you can see a marked improvement in the T2. Here's after his radiation therapy, so a lot of the blood has resorbed. The one thing about using bevacizumab in the newly diagnosed setting is you really get rid of pseudoprogression. In our large series, we went from about 35% to 1%. Because you get rid of that, the radiation-induced edema and a lot of the symptoms that go along with pseudoprogression. So it makes it a lot easier taking care of these patients. You know, pseudoprogression is really the bane of our existence. You don't know whether the tumor's progressed. Should you add more steroid? Do you need to biopsy the patient? Well, with bevacizumab, you really don't have that issue. The patient was able to complete his protocol therapy. He stayed on single-agent bevacizumab for a second year as kind of a maintenance, very similar to the Avaglio trial. He remained well with an ECOG status of 0, was able to return to work until about 3 years after diagnosis, when he again had a generalized seizure. His MRI showed progressive disease. He was restarted on chemotherapy and bevacizumab, has improved clinically. He's still on his treatment. Here's his MRI at 2 years. It's nice taking care of these patients when they come in 2 years and they're really living normal lives and the MRI looks completely clean. He may have been well if he wasn't treated on the bevacizumab trial as well. He's in that good group. He actually had an unmethylated MGMT, but with his performance status, a gross total resection, he is in that good prognostic group. So I certainly can't say whether the bevacizumab was responsible for his remaining progression-free, but he did. Here's the addition of bevacizumab prolongs the time to progression in resected newly diagnosed glioblastoma. I think it modestly improves the overall survival, but we really need the phase 3 studies. The patient's quality of life and performance status are much better as a result of the prolonged time to progression. The addition of bevacizumab to upfront therapy, I think, has a positive risk to benefit ratio. Next one is a tough one. We see a lot of these. It's about a quarter of the patients we see. This was a 39-year-old gentleman. He was a machinist, had done very well. He worked at the same place for 22 years. And he ended up being fired because he couldn't perform his job well. He started missing work. Nobody quite knew what was going on. He subsequently developed severe headache and continued to deteriorate with sleeping 16 to 18 hours a day. His wife ended up taking him to the emergency room. He was really quite apathetic, but he had no focal deficits. He ended up having a CAT scan followed by an MRI. He had a very large enhancing mass in the genu of his corpus callosum. It was really like a butterfly. Glioma was awful. Biopsy showed glioblastoma. Here's his large tumor when he presented to us the following week after his emergency room visit. You can see the two views with a large tumor. It's amazing the guy had been able to work until about 3 months before this. There's the FLAIR images, very well circumscribed, really not that much peritumoral edema, but it's in a bad spot. He had 8 more cycles after the 4 cycles of upfront chemotherapy and bevacizumab. If the patient is at least stable, then we proceed to the radiation. We continue the bevacizumab, continue the temozolomide. He ended up receiving 8 cycles of adjuvant temozolomide with bevacizumab and really just remained stable. He improved initially with those first 4 cycles, but then remained stable, but at least his performance status returned back to an ECOG of 1. There's the same thing. You see the really significant improvements. This patient participated on one of our clinical trials where we look at upfront chemotherapy. I think it's an excellent opportunity to look at the biologic activity of agents. We've done a number of similar studies with EGF inhibitors, with c-MET inhibitors. You really can tell very quickly if an agent is active or not. I mentioned that he improved after the first 4 cycles. He was able to return to his normal activities. He couldn't work as a machinist, but he was able to return to work in what we call light duty. He proceeded with 8 more cycles following the radiation. He continued to improve. The last 2 cycles, he was just kind of getting beat up, predominantly from the irinotecan. But he had a cold PET scan after the year of treatment. Surprisingly, he's remained progression-free, 26 months. This is very unusual. It's certainly less than 5% of these patients with unresectable glioblastoma, but he's one of them. As I mentioned, he improved after stopping his chemotherapy, as well as starting a stimulant. He was able to return to work ultimately full-time, and I mentioned his ECOG improved from 2 to 1. What about unresectable glioblastoma? I think that's one group where bevacizumab really has made a very big difference. You improve a person's symptoms and limit their time on steroids. The risk of CNS hemorrhage is not increased with the addition of bevacizumab. We were quite worried about this, but we really did not see an increased risk of CNS hemorrhage. Clearly, the time to progression is prolonged. The overall survival may be modestly prolonged in this very poor risk subgroup. From our data, their overall survival usually goes from about 6 months to 10 months. So a short improvement, but for the patient, I think it is meaningful. What about the difficult patient who progresses to bevacizumab therapy? A 67-year-old woman presented with confusion and focal seizures. She had a left frontal tumor. She underwent a partial resection followed by radiation temozolomide. She actually completed her 12 months of adjuvant temozolomide. She did have a methylated promoter. She ultimately developed more confusion, some aphasia, 4 months after stopping her temozolomide. An MRI showed obvious progression of her glioblastoma. She was treated on a clinical trial with bevacizumab daily, temozolomide, and an HDAC inhibitor, varinostat, and improved for 7 months. She progressed again. Her KPS had decreased from about 80% down to 60%. And these are tough ones, but how would you treat this patient? We always talk about hospice with these patients because it's tough. You know, their average survival is in the 3 to 5 month range, so we always bring that up. But here's her baseline MRI when she recurred. Here's after 7 cycles of the temozolomide, bevacizumab, and varinostat. You can see an obvious recurrence in the right frontal lobe. The radiologist called us up and said, boy, she's had an amazing response. Her tumor's so much better. I said, well, the patient's doing poorly. They just didn't pick up the non-enhancing disease. So you really have to look at the T2 flare when you take care of these patients. There's the baseline flare, and there's the obvious progression in the right frontal lobe. And you really wouldn't, you know, have picked it up unless you really knew how to take care of these patients. So what about post-bevacizumab progression? It really results in a poor survival. Average survival is in the 2 to 5 month range when they progress to bevacizumab. I think unless contraindicated by toxicity or the patient's choice, the bevacizumab should be continued. We used to stop it all the time, and that's when you see these explosions of tumors that Andres mentioned. So if you can continue to suppress VEGF, I think you benefit the patient. Unfortunately, other angiogenic cytokines take over. We found the best effect with reirradiation, either with stereotactic radiosurgery or IMRT, 5 days to a total dose of 20 gray, and you have to continue the bevacizumab, otherwise they get a lot of radiation toxicity. The other thing we've seen improvement with is a few young patients have improved with a PDGF inhibitor, imatinib or dasatinib, and/or an mTOR inhibitor, usually sirolimus we use, but they're in the 5% range. We've not found any chemotherapies that have been effective. So it's a tough patient group to teach, and we really need clinical trials. It's frustrating for us because we have a lot of these patients. I see probably 10 to 12 of these each clinic day, and we don't have any clinical trials because it's such a poor prognostic group. A lot of the companies, a lot of the cooperative groups don't want to study this group because they do so poorly, but I think that's what we really need to do. Where do we need to go? Clearly understand VEGF resistance. I think there's a number of other angiogenic factors that may synergize with an inhibitor of VEGF, either human placental growth factor, there's an antibody to that, angiopoietin 1 and 2 are other examples that may synergize with these. Neuropilin sits side by side to the VEGF receptor. These are studies that need to be done. And I think glioblastoma is the best tumor type to study anti-angiogenic therapy. It's so easy to image with fancy MRIs. You can really tell blood flow, a lot of different things. So you can pick up very quickly before the clinical deterioration whether a new agent is helping the patient. I think that's it. Here's just an example of a number of pathways that I think that could be inhibited. I mentioned the angiopoietins, fibroblast growth factor. We've done a number of studies with combined inhibitors of FGF and VEGF. We've not found them to be effective following bevacizumab progression, but that's one candidate pathway. But I think there's a lot of opportunities for good research. What we would love to do is a randomized phase 2 trial where you have a number of different arms where you study a new inhibitor and then you study the same inhibitor combined with bevacizumab for these patients. There's so many of these patients and they progress so quickly, I think we'll be able to learn a lot of science very quickly. I just listed some of the candidates that either we've done studies or are doing studies, but we really need to do them quicker. I think that's it. Muchas gracias.
RedLANO, Red Latinoamericana de Neuro-Oncología.